Is that it? Yeah.
Yeah. So as we said earlier on this, that we want to discuss the treatments for patients. Just moving this out. As we've been discussing over the last 5 minutes or 10 minutes, ITP is associated with physical as well as psychological stress in the patients that are affected. The key roles that nurses and healthcare professionals have regarding managing patients with ITP are, one of them is providing education on ITP to the nurses and to the healthcare professionals. That's one of my jobs, but it's also providing the patients, providing education for the patients and their families. Let's remember that the patient is not a single person. There's always a support system around the patient. And this is what we have a big discussion with the family. It's usually, sometimes the patient is not worried about it, but the family is more worried about it. So when we do the discussion, we discuss with everybody. We also talk about the treatment modalities. We talk about the management of side effects. We also provide, as I said, we provide support to the families to cope with all the psychological and physiological problems of ITP. Patients that I see in my clinic are new patients that come through our clinics, or A&E, long-standing patients with ITP, but they need a lot more involvement. Sometimes these are the patients that are relapsing, and sometimes it's harder to talk to the patients that are relapsing because they thought they were in remission and now it's all happening again, so you've got to deal with it, and you've got to deal with the patient. Patients with platelets below 10 and below 30, patients that we're weaning steroids off, I must tell you that whenever a patient is referred to me from another clinic, they've been on, some of the patients have been on steroids for nearly 2 to 3 years, and you've got to wean them off. And steroid weaning, and if they've been on steroids for a long time, it is almost like you're weaning them off a drug, like cocaine or methadone or anything. You've got to wean them so slowly because they develop, they get flu-like symptoms, they get terribly anxious and headaches and everything. So when we're weaning patients that have been on steroids for more than 2 years, we usually keep them on a very low dose until we can wean them off it. We even get to 1 milligram for about daily for about 6 months just to wean them off. We also weaning them off steroids and onto immunosuppressants. Remember, immunosuppressants take 6 to 8 weeks to work. So if you want a rapid change in platelet count, immunosuppression is not the way to go. I also see patients that are going for surgery and that need to have their platelets at a perfect level for their surgery. If they're having a minor procedure, platelets of 30 is great. So that is dental. Platelets are good at 30. If they're having any other surgery, 50 is good. But if they're having anything to do with their eyes or their spine or their head, we like the anaesthetists like platelets between 80 and 100. Also see patients that need IVIG, rituximab, fostamatinib, and other drugs. We see the patients that are needing TPA agonists, and we counsel the patients on the ITP medications, their effects and side effects. Thanks. Next slide. When the patients are admitted through through A&E, they're usually seen by the hematologist on call. I'd love to have a nurse on site 24 hours a day, 7 days a week, but unfortunately we can't. Patients are also referred to us from GPs for urgent consideration and are seen on our hematology day unit, either by the day unit doctor or the registrar. And they have the registrar and the doctors will then have a discussion with the consultant or myself about treatments and the frequency of visits. We then put the patients into an urgent ITP clinic, and if we can't get them into an urgent ITP clinic, I make sure that I phone them and introduce myself to them and book them into a nurse clinic a lot quicker than I can get them into an ITP clinic. And my discussions usually include our telephone numbers, my number, the hematology day unit number, our generic email address, my email address. I explain to them what happens, what is going to happen in the future and how platelets are playing in their general well-being. I also explain that it's going to impact on their day-to-day life, but I also reassure them that they're not going to die or bleed to death. This is the most important part of our reiteration and our looking after patients, is reminding them that they stand more chance of dying by walking across the road and getting hit by a bus. But they must know what to look for when they've got bruising and bleeding and headaches. Another part of my conversation with them is to find out what their lifestyles are like. Are they a party animal? Or do they do much exercise? Are they into fitness? What do they do? Because if they're in the acute phase, we're going to have to adjust their lifestyle a little bit for managing their expectations. The other thing that we need to find out from them is what they know about ITP and direct them to the correct sources for information. If you Google ITP, it will tell you it's a bleeding disorder, you're going to die because you're going to bleed to death, and you've got to reassure them. So I redirect them to the ITP Support Association, and then I give them my telephone numbers, because I tell them that they should actually just phone me before they go on to Dr. Google. And lots of reassurance. And don't forget, before they leave, they need to get given all the information for the ITP Support Association and the information leaflet. The reason why we give this at the first discussion with our patients is that they feel that they're not the only person in the world, because none of them have heard about ITP before. Nobody in their families had ITP. So we've got to reassure them that they're not the only people in this world. And before the pandemic, it was very nice, because on a Thursday we used to have the ITP clinic in the day unit, and patients would be sitting in the waiting room and suddenly find out that those 10 or 12 patients that are sitting in the waiting room have the same disease as they do. And they have a big chat about the disease, and they come in and they see me and they go, I'm so glad I met them. I didn't realize there were other people. And I say, it's one of the reasons why I would like you to join the ITP Support Association, because they have seminars like this one, there's patient seminars, and there's information. Next slide, please. Well, basically we can go to the next slide. My clinics are every Thursday, but I see patients generally all the time. And we have an ITP MDT every Tuesday at 2 o'clock with, or was it 1 o'clock? 1 o'clock. It's now a ITP MDT that is joined by Queen's University Hospital as well in Romford. And it's getting bigger every day, because before it was only the Royal London, and we all had a chat about our patients, and we know everybody, every patient. Now we've got Queen's, we've got Newham, we've got Whitcross, and I believe Homerton are going to join us as well. We also belong to the ITP Forum. Please, any of you that are not part of the ITP Forum, Mervyn will send you Quentin Heal's email to join the ITP Forum. And if you can, if you want to join the Nurses ITP Forum, please email me at l.taylor6@nhs.net. We do have meetings at least once every 3 months, but I have to say I am very disappointed in the turnout of these meetings, because usually it's myself and 3 other people that are on the meeting. Please join us for the ITP Nurses Forum meetings. Also, we tell you about all the upcoming events that we are going to hold. And there are 3 upcoming events in the next 2 months that are quite interesting. We're looking at the goals of ITP treatment according to the phase of the disease. The initial treatment is to obtain a safe platelet count. That is basically to get them past the bleeding symptoms. Some people do, I've got patients that have got platelets of 10 and they've got no bleeding symptoms, so I leave them alone. But you've got to take your patients and look after them according to your patient himself or herself, and knowing what they are like and what you need when you need to treat them. You've also got to look at the persistent disease. So are we going to give them the immunosuppression or a splenectomy? The new guidelines that came out in 2019, 2020 say that worldwide that we should defer a splenectomy for at least 18 months until we've tried all the other treatments, and that is the TPOs or rituximab or immunosuppression. The other point is the unresponsive, the severe refractory disease, even if it's after splenectomy or after several lines of treatment. This is the worst part of looking after ITP, and this is the one that I find quite difficult, is when we've treated the patient and we've tried everything. We've tried steroids, we wean off the steroids and they drop their platelets. We try IVIG and steroids. We try immunosuppression. We try TPOs. TPOs then work, and then they lose the effectiveness of the TPO. So we go to rituximab. That doesn't work. So this is, how do we minimize the bleeding and treatment toxicities, and how do we prevent them from bleeding? As I said on the slide, is an increase in platelet count is not our main goal. Our main goal is to minimize the risk of bleeding. Thank you. Next slide. The treatment options for ITP. First line is steroids and IVIG. Steroids, as I said before, 1 milligram per kilogram to a maximum dose of 70 milligrams. We try and wean them off rapidly over 6 weeks of steroids, and if we find that they are dropping their platelet count, now we have to go back to immunosuppression because of post-pandemic stuff. TPOs are not available up front anymore, but in acute cases, we can argue the case with our CCGs and we will get TPOs. So we will give them, so if we're weaning the platelet count, if we're weaning the steroids and we're giving them IVIG to prevent them bleeding, and we're weaning the steroids and the platelet count starts dropping, you don't wait until the platelet count is north before introducing immunosuppression, because remember, immunosuppression can take up to 6 weeks to work. We prefer to use mycophenolate, but we use azathioprine or cyclosporin or sirolimus. Makes no difference, whichever one is available, we use that. If that doesn't work and we're still dropping the platelet count, then we will discuss starting a TPO. This is either altrombopag, romiflostin, and in the near future, avatrombopag. Altrombopag is licensed after 6 months. Romiflostin is licensed of failure of first-line treatment. So that means failure of steroids and IVIG, but the CCG do not give it to you because they class romiflostin as chronic, and therefore you can only use it after 12 months. But depending on your CCG, we can get altrombopag and romiflostin within 6 months. Avatrombopag hopefully will be launched next month. It is similar. It's a similar molecule to altrombopag. Altrombopag is the oral version of the TPO. Altrombopag is a drug which is a TPO agonist, which means it stimulates the production of thrombopoietin out of the bone marrow to produce more platelets. It, unfortunately, with altrombopag, it has dietary restrictions. It must be given on an empty stomach, and it cannot be taken with any calcium or mineral supplements or anything containing calcium for at least an hour to 2 hours after taking the medication. Avatrombopag is a similar drug, but it doesn't have any of the dietary restrictions, and hopefully that will be available with nights at the end of December, beginning of January. Rituximab is an anti-CD40 monoclonal antibody. It works very nicely. In our department, we give 100 milligrams of rituximab once a week for 4 weeks. It has a similar effect as giving 375 milligrams per meter squared. We've got data to prove that it makes no difference which dose you're using. The data is the same, but generally rituximab works better in young females. But it does work in the older people. And if it works, also takes up to 6 weeks to work. But if it works, you can get a remission of 2 to 3 years. We've got other drugs, danazole, which is a chemo, sirolimus, which is an immunosuppressor, fostamatinib. Fostamatinib is a drug, and would you believe it? It's gone out of my head. Fostamatinib, it comes with it's now licensed in ITP in England. It was licensed for ITP in Scotland for the last 2 years, but it's only now licensed in the UK for ITP. The big problem with fostamatinib is its efficacy. It only works in refractory ITP, and it only works in about 20 to 30% of the patients. Another problem with fosta is that it has extreme gastric disturbances, and I mean extreme, that the patients have diarrhea while they're becoming while they're becoming accustomed to the drug. They have acute diarrhea, and for about 2 to 3 hours after the dose. And I mean, they can't go on the train, they can't do anything. But the 2 patients that I gave it to, none of them had any of those side effects. We've got new trial drugs, which is the PRN trial, which is a BTK inhibitor, risabrutinib, which we're also using in warm autoimmune hemolytic anemia, the Arginex study. We've now just opened the Arginex study which is effigatimod, in weekly subcuts. So if anybody wants, got patients that they want to send me, that will be good. UCB is closed. Bioverativ is doing a few trials and they should be available soon. We've also got a lot of complement inhibitor trials, but there are always trials available, and I'm sure the ITP Support Association has them on the website. If anybody is interested in sending patients to one of the centers, please let us know. As I said, the other treatment for ITP is a splenectomy, only after 18 months, and only if everything else fails, and only if you have done a platelet scan, which is an indium labeled scan, so that you can see whether platelets are being destroyed in the liver or in the spleen. If the 90% of the platelets are being destroyed in the spleen, take the spleen out if you want to, but why? If it is half and half, why do you want to remove a perfectly good organ? Next slide. When we're doing acute treatments, the patients are fast-tracked to hematology, either from A&E or GP. As I said, we treat them with IVIG and prednisolone. If the platelets do not respond, we redo all the blood tests. We redo every single blood test to see that there are no other causes for the low platelets. We then sit and discuss with the patient every single medication that they've been taking. We ask them about their their vitamin intake. Are they taking any mineral supplements? Are they taking any mineral shakes? Are they taking any Eastern homeopathic drugs? If we can't find a cause, we do a bone marrow biopsy. We do not generally do a bone marrow biopsy. Old guidelines said you do a bone marrow biopsy if the patient's older than 60. We don't do a bone marrow biopsy unless we are failing steroids and IVIG. If you're failing steroids and IVIG, there is inevitably another cause. But ITP is weird. ITP, you can have fail IVIG and steroids and still have ITP because the body just doesn't want to do it. ITP doesn't go according to a well-defined pathway. We treat with IVIG methyl platelet transfusions, but as I said about the platelet transfusions, remember, if you've got a platelet antibody in your blood system and you put in platelets, what are they going to eat? They're going to eat the platelets that you've just given them. So you do a platelet transfusion now, 2 hours later, the platelets are gone. When you do a platelet Indian labeled scan, they nuclear medicine label the platelets and they watch the destruction over 3 days. And it's quite interesting to see how platelets are produced and how quickly they are destroyed in ITP. We start immunosuppression. As I said, it takes 6 weeks for that to work. If it's going to work, it might work quite quicker. And we get funding for eltrombopag, romiflostin, and avatrombopag in acute treatment. Next slide. This is where we always struggle, is our challenges in ITP. Patients that have failed are not responding to first-line and second-line treatments. That is meaning poor quality of life, they can't get out of bed, they've got significant bleeding, they've had lots and lots of pulse steroids. You must remember, the biggest problem with patients is that they hate steroids, they hate the side effects, they hate the way they feel. So in the beginning, you would give prednisolone 1 milligram per kilogram, but if you have more acute episodes, we generally give a smaller period of time, usually 20 milligrams of dexamethasone for 4 days, just to tide them over. And sometimes that works very nicely. As I said, we try rituximab, but there is a 60% response rate. And the more frequently you have to give rituximab, the less likely that the rituximab is going to work. I mean, we've got a patient that's tried everything, and for the last 10 years, we've given her 3 doses of rituximab where she responded and she did quite well for 2 to 3 years. And the last time we gave her a dose, which was in March this year, she did not respond to rituximab, so she hasn't responded to anything else because she's got, when she was on romiflostin, she developed fibrosis of her bone marrow. And so we keep her going with IVIG every now and again when she needs it. And we've put it on, put it this way, half my refractory patients are my trial patients, so they try everything. So every trial that comes along, we put them on. We switch the TPOs. If they're on our Trombopag, we switch them to romiflostin. If they're on romiflostin, we switch them to our Trombopag. And in the near future, we'll switch them to avatrombopag. We will add in immunosuppression. We'll try triple therapy. Now, triple therapy is TPO plus steroids plus an immunosuppression, or TPO plus steroid plus rituximab. At the last resort, I'll try fostamatinib, and we have to apply for a IFR for sirolimus, but we have found that has worked. Next slide. So, as I say, we throw the patients, we ask patients to go on to ITP trials. When they get to the stage of being very, very refractory, and they're coming in once a week anyway to keep their eye on their platelets because they're getting significant bleeding, they're more likely to come in and do the trials, because unfortunately all these trials require weekly visits. Some of the trials require about 2 to 3 hours every week on one of the days every week. And some of them only require that they come in for a full blood count. But it is an extreme challenge to get patients onto these trials because of the time commitment that is needed for them. And the treatment pathway, which is usually 26 weeks once a week, for something that may not work for them. But we did the Arginex study and we had a 50% response rate. On 50% it didn't work, and we put them onto one of the other trials like the BTK inhibitors, and it might not have taken their platelet high to say it actually worked, but it decreased their bleeding. But you know, you give everything to your patient, and eventually, somewhere along the line, maybe we will offer them a splenectomy. Next slide, which says questions, I think. Oh, okay. Aspects of TPOs. When you're going to put a patient onto a TPO, you have a discussion with the patient on what TPO they want. You give them all the information on the TPOs. I say here that we give them information on the 2 TPOs, which is our Trombopag and romiflostin. You must have a look at their lifestyle, their age, their compliance, their comorbidities, also the patient preference, whether an oral or injection. The patient then decides what they want to do. You can guide the patient, but the patient is involved in all the decision making here. And if they're going on to romiflostin, then you start training them on romiflostin. But if they're going on to eltrombopag, you must remind them of the dietary restrictions. If they're going on romiflostin, you must have a look at whether they can give the romiflostin themselves, and you can teach them self-administration, or are they going to come to the clinic? If they're going to give it themselves at home, is it themselves or is it the carer? If it's old patients that you're worried about, then you involve your GP and your practice nurse or the district nurse to give them the medication. Another question is, will they follow everything and be compliant? And you must remember, this is before the pandemic. Is a weekly trip to the hospital too onerous? Before the pandemic, we just expected everybody to come to hospital. Nowadays, all the phlebotomy areas are all around everywhere. They can have a blood test done at the local blood test department. You get a result. I have very good contacts all over the country for results. I get a result, and then we have a discussion on the phone on what their dosing is going to be. And then as we go further and further into the treatment plan, is decreasing their blood tests and making them more stable and ensuring that they still have a clinic appointment once every 3 months. Please remember, if you're giving a patient a TPO, that they must see a consultant hematologist once every 3 months. Next slide. Any questions? Any questions? Nobody's asking any questions. Is that enough? They've gone home. Christina?
Yeah, I'm sorry. Thank you. I've looked at your slides and the information about combination therapies just because I'm actually currently experiencing a patient who is in my clinic where we have been trying various therapy for him. We have had eltrombopag. We're currently waiting for funding to get him on romiflostin. But he have completed three weeks of rituximab. I checked his platelet on Wednesday. It was 12. Then and I said, okay, because I was a little bit skeptical about the results because I was not seeing any increment. And then I said, oh, can you do another blood test for me on Friday? I know it's too close, but just for me to check. And then I found out his platelet have dropped to a 4, which is below the standard 10. So we end up have to give him IVIG. He seemed to only increment a little bit with IVIG, and it makes it so difficult. And I tend to do a lot of nurse-led clinic, but on a phone, not seeing him face to face. So I'm just wondering, what would be the best thing? Would you think he would be ideal person to bring to a face-to-face until his platelet count is well managed? Or
the thing is, when you do nurse-led clinics on the telephone, can you see the patient? Do they send you pictures of their bruising and bleeding?
no, I did ask him to send a picture, but I never got it. But he came in, had a blood test, and then I had to end up bringing him to A&E because
Where's he having his rituximab?
In our day unit.
Generally, if they're having rituximab, I go and visit them face to face to see how they're doing. I would, if that was me, I would discuss giving him immunosuppression as well.
He has had that before. He had an MMF prior. It didn't work.
Do you give them methylpred with their rituximab?
No. He just went in just for the rituximab.
Yeah, sometimes when we find that these patients are not responding quite quickly with rituximab, we'll give them some methyl-pred with their first dose and second and third dose. We give them 500 milligrams of methyl-pred. But you've given them IVIG, so that should cover him for about 2 to 3 weeks. How long does it take for your romiflostin to come through?
Well, he was not due until end of October to be able to get the funding for it. So we try to see if we can get it sooner than that for him, because he has failed all the various line of therapy. So it is difficult. I don't know. We're waiting for
These are the patients that are very, very difficult. The thing is, I know I have lots of these, and basically I do exactly what you're doing. Give IVIG, give them prednisolone, or dexamethasone. Give them, when they drop their platelets to 4 in there, I'd give them dexamethasone for 4 days. And hopefully that takes them over for about 3 to 4 weeks, the dexamethasone. If the dexamethasone doesn't work, then do a bone marrow biopsy.
Okay. All right. Thank you very much.
But give me my email. Mervyn's given my email. If you want to have a chat with me, send me an email and then I'll phone you.
Okay. Thank you, Louise. Thank you.
Louise, would that also be a good question to put to the ITP forum? Because I've noticed of late they've been, sharing difficult cases, etc. Like, trying to get a consensus on. Yeah.
The consensus has been, because that goes, we put those type of things onto the ITP forum, and everybody that puts their thing or puts their expressions of ideas in on the ITP forum, and inevitably it's everything that we've done anyway, and it's basically going back and the restarting again, is redoing all the bloods again to see that they haven't developed something new, is giving them rituximab, giving them triple therapy. So he's on eltrombopag. He's having rituximab. You've got 4 weeks to the end of October, and then he can go on to romiflostin with a bit of that. And if they give them dexamethasone for 4 days, it might keep him safe as long as he's not bleeding. If he's bleeding, then that's when you go into the acute management of admitting them and probably giving them 2 lots of IVIG over 4 days, one lot one day and 4 days later more IVIG if they're bleeding. Bleeding. If a patient is bleeding, it changes every possible aspect in your life. Then you throw everything at them that you can get, and that's when you take. Basically, that's also when we take the hit from. We put it through to our chairman's action for the other TPO. If they're not going to approve the TPO or the fostamatinib, we put it into the chairman's action, and generally they approve it within 24 hours on the chairman's action.